crisp breezes, Halloween pumpkins, gorgeous autumn leaves, and the melodious sounds of croup fill the air. We pediatric caregivers rarely deal with the scary heart attacks and strokes in adult medicine, but our emergencies are pediatric airway obstructions. Welcome to Season 2 of the podcast Pediatricians. Our disclaimer, we are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care.
And remember, you can catch us on podcastpediatricians.com, on iTunes, and now on YouTube. Newly, Rob has managed to make that transition for us, as well as the usual sources of iTunes, Stitcher, and Google Play. A young child's upper airway, or windpipe, or trachea, is about as wide as his or her pinky. As you might remember from 9th grade trigonometry.
Well, actually, for me, I took it in 8th grade, Matt.
Of course you did, Rob. The area of that circle is area equals pi r squared. So a little mucus and swelling can really drastically reduce the area of the windpipe. It's available for the transmission of air. Now, the trachea is in the neck above the chest, and as it gets narrower, it tends to collapse on inspiration or when breathing in, just like when you suck on a straw that's really cheap.
Do you remember kindergarten? Did you have that?
Yeah, like the cardboard straws.
Yes, in those little things of milk, and they were so cheap, and they just
absolutely.
You went.
Now, I didn't really get to appreciate those outside of snack time because I don't know if I ever told you, but I used to walk home for lunch.
Me too.
Did you?
Yes.
Get out. We're like the only two people ever with that.
It was
I only
great.
lived 3
In
blocks
fact,
away.
And the classic, I'd walk home for lunch and watch Bewitched and That Girl for lunch and eat. What did you eat?
You got an hour.
What did you eat?
Well, first of all, I used to watch Kimba the White Lion, and I always missed the last 5 minutes, so I never knew how Kimba got saved, but just knew that he did because it was the next day. I told a parent that about 10 years ago in my practice, and they actually downloaded all of the Kimba episodes for me and gave it to me on a DVD.
I was just,
cool.
I had a young crush on Elizabeth Montgomery.
Oh, I was more of a Marlo Thomas guy since you said That Girl. Yeah, but anyways.
And what did you eat?
Oh, so when I went home, it was almost exclusively graham crackers and peanut butter. And that was a timing thing. You had to be able to dip the graham cracker into the milk. Not too mushy, not too hard, just right.
I was SpaghettiOs with the little hot dogs. You know?
That explains a lot, too.
My mom was not an early riser, and that's what she could manage for me. Although back then we didn't microwave it, but it was SpaghettiOs.
Well, on Fridays we had tuna fish at my house. At what point did you start eating lunch at school?
When I moved and in 5th grade.
Okay. I was 7th grade, actually. And the reason I ate lunch at school wasn't because I didn't enjoy going home, but I enjoyed playing dodgeball and kickball much more.
Oh, King of the Hill? Kill the guy with the ball?
Yeah,
love that.
Absolutely.
Me too.
Well, anyway, so what flavor of milk did you get? Or did they not have
they only
that
didn't
kind
have
of diversity?
It was 1967. It was just white milk in a very cheap container with a cheap straw.
As I recall, we had chocolate milk for 5 cents. No, I'm sorry, white milk for 5 cents and chocolate milk for 7. But I tried to save my money because that was the one place I could consistently get ice cream. And that was, I think, 15 cents. So that was a little bit of a push. That was pretty much full allowance there. What did you have a favorite ice cream?
Matt grew up in the Depression era.
The Dust Bowl of Merchantville, New Jersey. Did you have a particular ice cream at lunch that you
ice cream
favored?
Sandwiches. That was
I had to work my way into them. I was more of a chocolate eclair guy.
Huh?
You know, I'm not sure why they call them chocolate eclairs because it was more like a popsicle of vanilla ice cream with little kind of crunchy things on the outside.
Yes.
You know the one I'm talking about?
I got those from the Good Humor Man.
Did you? Okay. But, well,
We digress.
all roads lead back to milk on this show. All right. So let me see here. So back to croup. So nothing's more frightening for parents of young children than having a child suddenly suffer from upper airway obstruction. With that barking and stridor, it sends somebody into a frantic state completely.
Yeah, probably the only thing worse that we routinely see is when your child has a febrile seizure. Because then you're thinking they're possessed by the devil and they're dying.
Scary.
But acute croup is really bad. And I remember some of my toughest call nights were spent listening to barking toddlers in their Croup Tents. Do you remember the Croup Tents?
I do. Those are vicious little torture chambers.
Yeah, not only that, they had respiratory distress, and you put them in something where you can't even see them
can't
anymore.
see them.
Like, how they look, I don't know.
It was like a bad movie. There was this noise in the mist, like, and you knew you were supposed to be afraid of it. It was crazy stuff. So viral croup, which is also known by its proper name of laryngotracheobronchitis. And I try to make that clear to the parents I see in the practice because it really identifies the parts of the upper airway that are affected. It's a common childhood condition occurring at some point in about 15% of kids. It's a respiratory illness characterized by inspiratory stridor, which is this breathing in kind of drama, a barky cough, and then hoarseness. So hoarse speech. So hey Rob, what's up?
It's funny with hoarseness, with other illnesses, just, allergies, such. Parents are always concerned when their kids lose their voice.
Yes.
And for us, it's like, yeah, you got some mucus in your larynx, but it doesn't necessarily mean anything else.
No, and it's interesting, and I think that any parent listening might want to take heed to this, that many times people will bring their child in because they've lost their voice and fear that they may have strep throat, which the two are kind of, what's the right word for that? What term for that? Non sequiturs, like they don't fit together.
Not connected.
Not connected at all. So anyway, back to croup, the phenomenon that result from the inflammation of the larynx or voice box and of the subglottic airway or the top of the windpipe is really what is causing the croupy symptoms. This is in contrast to the phenomenon that occurs in asthma, where the inflammation is primarily in the small airways of the lungs within the chest itself. Inside the chest, the smaller airways tend to collapse on expiration or exhalation, and so there's typically a wheezing when breathing out. And occasionally, if it's really, really bad, there's a wheezing breathing in as well.
Now, classic viral croup occurs mainly in infants and toddlers, about 6 months to 3 years old. It's uncommon over age 6, but can be seen as old as 15. And barking is the hallmark in the younger kids, and hoarseness is more the norm in the older ones. The most common cause of croup is the Parinfluenza Virus type 1, N2, N3, although RSV, which is the classic wheezy virus, can also cause it, as well as adenovirus and coronavirus. Several vaccine-preventable diseases, like influenza and measles, can also cause croup. But the all-time classic and deadly croup disease over the ages that literally choked to death millions of kids for centuries is diphtheria, which thankfully is rare in developed countries now because of vaccines. Now, hey, Matt, do you know why viral croup is called faux croup in France and false croup in England?
Because they speak two different languages?
Yeah, that's kind of correct, but I'm not giving you credit. Well, it's because in Western Europe, croup meant diphtheria and possible death. So they called viral croup false croup or faux croup. And you always wanted to have the false croup, not the real croup of diphtheria.
Wow. Well, did you know, and just to touch on diphtheria for a second, because I'm not sure we can dedicate a whole episode to that these days, diphtheria became a real problem when the Soviet Union broke up, from what I understand. So within 6 months of the Soviet Union breaking up, and because of that vaccine supply issues, over 50,000 people contracted diphtheria within 6 months. Astounding.
I forgot that. I remember, because that's early in our career. I remember when I talked about diphtheria to parents, they say, well, this is something they see in Russia.
Yes.
So that explains it.
Crazy stuff. We should also mention the term spasmodic croup, which is sometimes used interchangeably with croup. This term is often used for the sudden onset of croupy signs and symptoms, often without the mild early cold symptoms seen in typical croup, and tends to be in older kids. It's sometimes associated with allergies or reflux, and is much more likely to be recurrent, but there can be overlap with regular viral croup as well. So viral croup is mostly seen in the fall and early winter, and the symptoms tend to peak at night. This is likely due to the fact that at night a child's lying down, which can cause more mucus pooling and can cause changes in the blood flow to the lung, as well as the fact that there is often drier air in a home at night, and there are decreased cortisol levels at night as well. Often the symptoms come on suddenly in the middle of the night. This is very scary. Typically the child may have a mild cold for a day or so, and then, soon after they go to bed, comes the sudden barking and stridor. Absolutely scary as heck for parents.
And do you remember the good old, bad old days before the H flu vaccine came on the scene in about 1987, when the big worry and the big teaching about stridor in children was make sure it's not the dreaded epiglottitis. That word epiglottitis struck fear in all pediatric caregivers. It typically occurred in children a bit older than croup and also usually had a higher fever. These children seemed much more anxious and were possibly drooling, and they had this very characteristic way they cocked their neck and their back to keep their airway open as much as possible.
Yeah, that was really, I've only ever seen one case of that, Rob, but really they kind of plunge their head forward and kind of cock their neck up.
It's funny, I've seen multiple cases, probably because
you're so much older than I am?
Yeah. But no, I started training, you started a little bit later in your career, and I started earlier. So my early training was the 3 years before the vaccine came out. So we saw a lot of epiglottitis.
Well, as I recall, I mean, when we were training, the textbooks would say something along the lines of, if the child survives long enough to get to the hospital, this is what you do. So, I mean, I have rarely read anything that was that really dramatically scary, in pediatrics. So anyway, just to explain this a little bit more, the epiglottis is a flap of cartilage at the base of the tongue that more or less covers over the trachea or the windpipe when we eat or when we drink, so we don't aspirate food or fluid into our lungs. Epiglottitis could quickly lead to full respiratory arrest and death in young children. If you have time and you're careful to always have someone nearby to control the airway, you could get a lateral neck x-ray, which shows the classic thumbprint sign of epiglottitis, which was always on the pediatric boards way back then.
Always. It's
like the only picture on the pediatric boards. What is that?
There's a picture. That's
There's the thumbprint. Absolutely.
Epiglottitis is one of the reasons back in the day when we routinely used to get x-rays for croup. And on the AP or frontal view in typical croup, you saw something called the Steeples sign, like the top of a church, which represented the narrowing at the top of the trachea. So you always wanted to see a steeple, not a thumbprint. Matt, when was the last time you got x-rays for typical croup?
Oh, gosh, probably back when I was a resident in the emergency room.
Right? Never.
When was the last time you did, here is the church and here is the steeple, open the door and see all the people?
Well, you do that like on a weekly basis, so
probably even more often than that. Depends on my crowd.
I didn't know you wanted to share that with everybody.
It's a lost art.
Looking at an airway, these days you're more likely to do airway fluoroscopy to look dynamically at the airway, or even to get your friendly neighborhood ENT to do a quick scope if you're worried about atypical upper airway problem. Now, H. flu, or Haemophilus influenza type B, causing epiglottitis, is a bacteria, not an influenza virus. And it can also cause sepsis and meningitis and pneumonia, but epiglottitis was the unique and infamous disease attributed to H. flu. Often with epiglottitis, to save the child's life, it meant intubating or putting a smaller than usual tube past the inflamed epiglottis into the windpipe to keep the airway open until the infection eventually resolved. This was difficult. This was harrowing. I did it once with a pediatric intensivist, literally with his hand on mine, pushing it through and past the epiglottis into the airway. And the epiglottitis, it looked like mashed raw meat.
Yeah, it's scary, just scary on all levels.
Did you ever see anybody die of epiglottitis?
I haven't.
I saw it once, and unforgettable. It was a child on transport that we thought had epiglottitis, and we told the local doc there, who, as I recall, had some anesthesia training from years before, not to intubate that child until the team was there and they can do it in a controlled situation. But he went ahead and intubated the child in his office, and unfortunately he intubated the esophagus or feeding tube of the neck. And by the time the child came back, she was brain dead and passed away. So it is a sobering example where a little knowledge sometimes can truly be dangerous. There's no greater example during our careers of the miracle of vaccinations than the H. flu vaccine. And probably I'll throw in the 90s, the pneumococcal vaccine.
When people ask me what my experience has been with these vaccines, probably the most dramatic part of what I've seen with vaccines has been the fact that when I started my residency as an intern, we were still seeing a fair amount of Haemophilus influenza B, especially meningitis. By the time I was done my residency, so a short 3 years, we started to not see it at all. In fact, statistically, I think that the incidence of Haemophilus influenza B meningitis decreased by something like 97% over the span of 3 to 4 years. And there's just nothing else to explain that except for the efficacy of vaccines.
It's mind-boggling.
Really mind-boggling.
It's a modern miracle.
It truly is.
And that's where You talk about non-vaxxers, it makes our head spin. And we are going to do an episode on non-vaxxers later this year.
We certainly will. Since croup usually hits at night, we usually hear about it from parents while we're on call. We can actually sometimes hear the barking and the stridor while we're speaking to the parents on the phone. So oftentimes they're holding the child in their arms, and we can hear these very distinctive sounds. When do you worry when parents call? Well, most of my concerns surround the child's work of breathing. You must take into consideration the child's history. If they have a known airway issue or already have a known lung problem, like a preemie with BPD, bronchopulmonary dysplasia, or muscle problems which could compromise their ability to breathe, or if they've had severe croup in the past, then closer attention obviously has to be paid to the situation. You try to gauge how significant their breathing distress is, which can be difficult over the phone. Are they alert? Are they drinking okay? Are their ribs deviating in and out? Do they seem to be short of breath? Is there significant stridor at rest? Again, stridor is that sucking in kind of, turbulent sound. We get to that point, and these are the tools that we have over the phone in order to assess a child.
Now, in the office the next day, after they get through a night with maybe some mild croup, they often look completely perfect. And a lot of the diagnosis I find is by history. And one thing to remember is a lot of these kids with croup, with classic croups, often get an associated ear infection. If we do see them in the office with croup symptoms, you can use a classic croup scoring system called the Wesley system. And it's scored from 0, which is perfect, and 17, which is really, really, really bad. They need to probably be intubated. And it's based on level of consciousness, cyanosis or blueness from lack of oxygen, the amount of stridor, their air entry, and retractions. Now, I read about this, and I have to admit I totally forgot there was any kind of croup scoring system because, as we'll talk about with steroids, it just doesn't come up anymore. How about you?
No, Rob. In fact, I had to remind myself after you had just said this that there even was a croup scoring system.
I vaguely remember there was something.
Yeah. Mostly for in the hospital, I guess. So as with other breathing problems, like asthma, you have to be careful about the value of a scoring system and really trust your general gestalt of the child and their situation, as well as the course of the illness. Sometimes, as they tire and get worse, the degree of stridor and the work of breathing may actually seem like they're getting better and less dramatic because, honestly, they're just tiring out. And that's where things get a little bit dangerous. So a croupy child certainly should be seen immediately if they're experiencing a great difficulty with their breathing, having really significant stridor, especially at rest. And I always tell parents, honestly, if you're scared, you're there, I'm not. You really need to do what you need to do and get that child seen as quickly as you can. They should also be seen if they're having severe coughing spells or not drinking well or having difficulty swallowing or increasing fatigue or, frankly, just getting worse overall. If they're really struggling to breathe at home or appearing blue to the parents or the caregiver, then obviously those parents or caregivers should call 911 and not risk getting into the car to go to the emergency room. We'd be remiss if we didn't mention some other pediatric conditions that can cause upper airway obstructions or stridor like sounds with kids. Things like foreign bodies in the airway or congenital, which means from birth, lesions in the airway like papillomas and hemangiomas, and also vocal cord paralysis, which itself is an interesting subject sometime we'll talk about. Certainly we need to think about these types of things with atypically presenting croup situations.
And then there's the classic croup gone bad, when a seemingly typical case of viral croup all of a sudden does not get better and actually acutely worsens, sometimes associated with high fevers. Sometimes this condition, which is called bacterial tracheitis, is not diagnosed until the child's intubated and pus immediately shoots out of the airway, and you never forget when that happens.
Yikes. Have you ever had that happen?
Once.
I've had pus come shooting at me from a couple different places on the body, and it's never pleasant.
Nope.
Never pleasant.
Peritonsillar abscess, I think, is the classic.
I think I got to get back to wearing my glasses. Okay, when we come back, we will talk about the treatment for croup, including the most effective treatment, for which neither one of us, I think, actually pursue the recommended guidelines.
We're back for a short break, and one of our listeners a few months ago reached out to me and asked me if Matt knew about the Jersey Devil. I did not know, except for the hockey team, which I never really understood why they were called that. Perhaps they were devil worshippers in Jersey. But I did not know, and so I got some information on Wikipedia. But Matt, Do you know about the Jersey Devil?
Well, of course I know about the Jersey Devil, man. I'm from Jersey.
What do you
we
know?
We all know about the Jersey Devil. So as I recall, the Jersey Devil was this evil being that lived in the Pine Barrens, not my neighborhood, but lived in the Pine Barrens and would terrorize the locals, periodically eating some and otherwise just maiming them and tearing them to shreds. We used to propagate these stories around campfires or at s'mores parties in somebody's backyard, like, ooh, tell a scary story. Make it about the Jersey Devil. So there's always plenty of blood and pine cones and stuff like that.
And you're absolutely right. A legendary creature said to inhabit the Pine Barrens of southern New Jersey. This creature is often described as a flying biped with hooves, but there are many variations. The common description is that of a kangaroo-like
Good day, mate. I'm the Jersey Devil.
With the head of a goat, a leathery bat-like wings, horns, small arms, and clawed hands, cloven hooves, and a forked tail. It has been reported to move quickly and as often is described as emitting a blood-curdling scream.
That sounds like one of your old girlfriends from Syosset.
Oh, this is... no, I was going to say this sounds like a typical Pines Barrens person. But here's a picture of the Pines Barren I got off of, and most of this stuff comes off of Wikipedia. And please support Wikipedia. And here's a picture, Matt. Do you recognize this? From school, perhaps? Family reunions?
No, the head was more human-like, as I recall it. That one looks like a cow.
Well, Burlington, New Jersey claims to be the birthplace of the Jersey Devil.
That's the next county over from where
In
I grew up.
1735, Mother Leeds was in labor on a stormy night, and gathered around her were her friends, and she supposedly was a witch, and the child's father was the devil himself. Remember, this is Jersey, so it is plausible. The child was born normal, but then changed form. It changed from a normal baby to a creature. It beat up everyone present and flew up the chimney, and it circled the villages and headed towards the pines. In 1740, a clergyman exorcised the devil for about 100 years, and it wasn't seen again until about 1890. Now, the frightening reputation of the Pine Barrens may have contributed to the Jersey Devil legend. Historically, the Pine Barrens were considered an inhospitable land, with gangs of highwaymen such as politically disdained loyalist brigands known as the Pine Robbers, and they were known to rob and attack travelers passing through the Barrens. During the 1700s and 1800s, residents of the isolated Pine Barrens were deemed the dregs or outcasts of society. Poor farmers, fugitives, brigands,
Les Miserables,
poachers, moonshiners, deserting soldiers. The so-called Pineys have sometimes fostered certain frightening stories about themselves and the Pine Barrens to discourage outsiders or intruders from entering the Barrens. So when did the Gottholds arrive in the Pine Barrens?
As I keep trying to explain to you, the Pine Barrens really aren't where I grew up. But I will say that you can still, not uncommonly, see bumper stickers in New Jersey, South Jersey in particular, that say Piney Power.
Nice. Although you still, you very cleverly did not answer my question about where the Gottholds and other ancestors.
I would like to have that remain a mystery.
Due in part
Although
to
brigand, I think, is thrown around in family parties.
Due in part to its isolated and undeveloped nature, the Pine Barrens have encouraged various folk legends. Apart from the Jersey Devil, many other legends are associated with the Pine Barrens. Supernatural creatures and ghosts are said to haunt the pine forests and include the ghost of the pirate Captain Kidd, who supposedly buried treasure in the Pine Barrens and is sometimes allegedly seen in the company of the Jersey Devil. The ghost of the Black Doctor, a benevolent spirit of an African-American doctor who, after being forbidden from practicing medicine due to his race, entered the Pine Barrens to practice medicine in the isolated communities of the Barrens, and is said to still come to the aid of lost or injured travelers. Also, the ghost of the Black Dog, which, unlike many Black Dog legends, is usually portrayed as harmless in the Pine Barrens, and also the ghost of the golden-haired girl and the white stag, a ghostly white deer said to rescue travelers in the Barrens from danger.
White stag, golden-haired girl, black doctor, black dog, black beard, and And the Jersey, that's like enough for a poker game. All kinds of people running around in the pines.
It continues to better my understanding of you, Matt, and how the Pine Barrens profoundly affected you as a boy. And perhaps the Jersey Devil also haunted Bruce Springsteen, causing him to give those shrieks while he is singing.
Well, there is indeed a Springsteen album. I'm not sure if you're familiar with it since you know nothing about Springsteen, despite the fact that you have tickets to go see him on Broadway. A Springsteen album known as Devils and Dust.
Ah.
Yeah, there's something to that, I think.
He may have the black dog in him.
Yeah. Mm-hmm.
We'll be right back.
We're back, and now we turn the discussion to treatment options for croup. So, of course, there really is no treatment for the actual virus that causes croup, which most commonly, as we said, is Parinfluenza virus, but which can also be a variety of other upper respiratory viruses. Treating the symptoms, though, really starts with keeping everyone calm. That includes the child, and that includes the parent. Particularly if the child gets upset, then they start to breathe more heavily, and the barking and the stridor only gets worse. So it's like they're working against themselves. If there's a high fever, then acetaminophen or ibuprofen can help, as can gently encouraging some fluids.
The hallmark of treating croup at home for generations has been humidity. Turning on the hot water in the shower to steam it up and then sitting in the bathroom and breathing in the steam, but not sitting in the shower. I did have one family who actually climbed in the shower.
I've had families do that. They found relief from that.
They were wet. A little embarrassed when I said I didn't mean for you to go in the shower.
That's okay.
It still helped. And also having humidifier at the bedside. You got to make sure that the water is clean and specifically that they use room temperature or cool humidifiers, since invariably if you use a hot humidifier, someone will trip over it and burn themselves. And we don't need the croupy child to also get scalding burn injuries. Another home remedy can be cold night air, which actually does seem to help, although I don't know many studies about it. I tell moms they can open up the freezer and have the child breathe in the cold air on really warm nights, or on a cold night, they can bundle up the child and go outside. And the classic croup scenario is if the parents do decide to go to the ER, they bundle the child up and they go outside and get in the car on a cold night. They get out of the car, they walk in the ER, and by the time they get inside the ER, the stridor, the barking are completely gone.
Yeah. In fact, I don't know if you get these calls, but I have over the years gotten quite a few calls from people who had driven to the emergency room with the windows down to keep the cool air moving, and they park, and the child seems fine, and they call me and they say, should I still go in there? And that's a hard question to answer.
I have a $250
copay.
Copay?
Yes,
I go into the ER?
It's a tough one.
Right?
Yeah, it really is. When somebody already at home has a nebulizer, which a lot of our families have just from their experiences with wheezing, if they have a nebulizer, I'll oftentimes suggest that they use that more or less like a high-intensity humidifier, but with just saline. You do not want to use albuterol with that. And that's because albuterol is a bronchodilator, and the way it works is it relaxes muscles. And so if you're already relaxing muscles where the tube is already compromised from the standpoint of its diameter, then you can even compromise the breathing more. So just heads up on that. A lot of the families out there will say, oh, this sounds like his asthma, and put the child on some albuterol. And I can't tell you I've ever seen any disasters from that, but in theory, it's not a good idea.
And a corollary to that, a lot of families will give inhaled steroids that they have. We'll get into steroids as the treatment, but the studies on inhaled steroids for croup are not that impressive. Right. But it probably won't hurt anything, and you're still getting humidity.
Right. It's a relatively harmless endeavor, but I think if a child's in danger, I wouldn't rely on that. So what you don't give is cough medicines, which really don't help cough anyway. But with the idea in mind that you're trying to stop a cough medications are not the thing that should be utilized in croup. By far, the centerpiece of pharmacologic croup treatment is steroids. In our early days of training, it was only given by IV in the hospital, and even then, only really sparingly. As we mentioned in the past podcast, for years there was a disconnect on oral steroid use for croup between academic centers and those of us who are in the community. The academics insisted on needing more studies to show us that oral steroids in the outpatient setting was safe and effective, while we in the community really knew that it worked because we had seen it and it was really one of our go-tos for our patients in that type of situation. Now, the official recommendation for most croupy kids is for a single dose of oral dexamethasone. 0.6 milligrams per kilo, with a maximum, some books say 10 milligrams, others say 20 milligrams per dose, and only one dose. So, of course, as with all oral steroids, it tastes pretty nasty.
Disgusting.
Very disgusting. What do you do, Rob, in the case of croup?
Well, I don't follow these guidelines. I use prednisolone, 0.5 milligrams per kilogram, which is usually about half of what I'd use for asthma, and I give it twice a day for 3 days. And I was taught this by the original Dr. Matt, the late, great Dr. McDermott. And I can't tell you how many times over the years I've had a child bounce back to my office with worsening croup after getting that single dose of oral dexamethasone in the ER or urgent care. And I also can't remember any child I treated with these 3 days of prednisolone who ended up back with me or in the ER with worsening simple viral croup. What about you, Matt?
Well, a couple things. A lot of my partners do indeed use the dexamethasone single dose with I think, good effectiveness. That's never been my tack, though. I'll usually use, similar to you, I'll use actually 1 to 2 milligrams per kilo divided twice a day over a series of 2 to 3 days, kind of depending on where I came in the process of the croup situation. But the other thing that I think makes me feel more comfortable with it is you're getting kind of a more even keel release of the steroid. Now, I'm no pharmacologist, but to me it makes sense that if you're giving 6 doses over a span of 3 days as opposed to one big dose, that my hope is that the pharmacokinetics there are more even keel. And also, I'll be honest with you, some of this is psychological. It's nice for the parent to know that they're giving something over a series of days and having expectations along that realm.
Have you seen those kids who get the single dose and they're coming back?
I absolutely have. That's not an incidental finding. I mean, that's something that really is very scary for the parents because they saw the child at their worst and they fear that they're getting back to it after they'd been assured that everything was going to be okay. So, I think both processes are reasonable, but I have my own reasons for using the 2 to 3 days of prednisolone.
All right, we may be dinosaurs, but we agree on that. So my big question for you, Matt, and it's a tough question, do you ever treat croup with steroids by phone? We already did a little rant about telemedicine. Do you ever give it by phone? Okay,
so this is a really very specific type of a situation that one encounters overnight. Again, Rob and I have already discussed the fact that it's very difficult to assess somebody's breathing simply over the phone. And there may indeed at
even
some
if you
point,
can see them.
Right.
You can see this tugging, but you can't hear the air movement.
Right. So there may at some point be a place for video in that context. But I'll say that unless I'm extremely sure of the parent's skill set, meaning their comfort level with things, and also extremely familiar with the child, I really hesitate to do this over the phone. Not to say that I haven't, because I do. But it has to be a certain child, a certain parent, and a certain case. And that's the way I usually approach it.
Exactly. The right child, the right family, usually in a setting of they've had it before, it's recurrent, they've done all the usual things.
Yes.
Sometimes they're out of town.
Yes.
And then I can feel comfortable. The other thing I find typically is for most simple viral croup, it's the second night that's worse than the first. So if they come in, had a little bit of stridor, not too bad, and again, the next morning they look fine, I'm going to treat them because I know that second night's going to be worse. I'm not going to get lulled into thinking, maybe it's not going to get bad, and then it's 9 o'clock that night and the kid's much worse than the night before and they're frantic. Right.
And I think in our ongoing crusade against commercial telemedicine, let me just be very clear about the last thing that we talked about. This is a family that A, we know well, B, we know the child well, and C, we know their capabilities in terms of their comfort levels. And D, we also know that they are not going to hesitate to call us back if things start going south. That's the difference.
Exactly.
Okay, so hospital and emergency room croup treatment can include really a wide variety of things, including the steroids that we already discussed, but also including oxygen and repeated racemic epinephrine nebulizers. So that's where one actually takes liquid adrenaline, or epinephrine, and makes it into a mist, which the child breathes in, and that causes the inflamed areas to essentially shrink back against the walls and give the child a lot more comfort with their breathing. Back in the day, we always worried about them, what we call rebounding, after that epinephrine, and so they all got admitted to the hospital so we could watch them overnight at minimum. Nowadays, with careful monitoring guidelines and with steroids, these children can oftentimes still go home, although they need to be watched in the ER for a series of hours until everybody's comfortable in doing that.
Right. These are like maybe 5% of viral croup that really can be scary. In some cases, I've read they've used Heliox, which is a combination of helium and oxygen. for overwhelmingly severe croup, all to try to avoid having to intubate or put a tube in to breathe for these kids.
So lastly, what about those older kids who have recurrent spasmodic croup? Well, certainly if croup is atypical and or recurrent, especially if there are any other physical findings or any growth issues, perhaps an imaging of their airways, and getting an ear, nose, and throat doctor involved to look at their airway is a reasonable course. And most times, everything's usually fine, and they end up outgrowing it. But you do have to do your due diligence if somebody's having recurrent cases of croup, and it doesn't seem to fit the classic picture.
Right, those classic spasmodic older kids. I'm much more aggressive looking for allergies, starting allergy meds on these kids, and considering reflux and even eosinophilic gastroenteritis.
Really? Have you seen eosinophilic?
Once.
Okay. Once is all it takes to put it in your mind, right?
Right.
So that's a wrap. Don't forget to sign up on podcastpediatricians.com and receive bonus material, and check us out on YouTube, as well as the usual sources of iTunes, Stitcher, and Google Play. Hope to see you at the Podcast Pediatricians Grand Rounds on Friday, December 8th at Christiana Hospital in Newark, Delaware, 8 a.m. sharp.
Snacks are provided.
Snacks are provided. This summer at Hot Topics in Pediatrics, July 26th through 28th in Disney World.
And again, if you like this, just get one other person to download some episodes.
Yeah,
we
it
appreciate
gives us a little emotional shot in the arm.
like it.
We
Yeah.
appreciate it. Say goodnight, Rob.
Good night, Moon, and good night, Weebles.
Who let the dogs out? Who let the dogs out? Who let the dogs out? Who let the dogs out?
I see the young people at the balcony, Billy Fountains get out. Get back, Gruffy, bash Gruffy, get back, you flea infested mongrel.
Podcast Pediatricians Productions. All rights reserved.